hypocalcemia. The text has been taken from the Oxford Handbook of Endocrinology. So the common causes of hypocalcemia include hypoparathyroidism, which could be related to the destruction of the parathyroid glands because secondary to surgical, autoimmune conditions, radiation, and infiltration. This could be related to failure of parathyroid gland development, um, which could be isolated, that is X-linked, and with other abnormalities. And the example is DiGeorge syndrome with thymic aplasia, immunodeficiency, and cardiac abnormalities. Uh, there could be a failure of the PTH secretion secondary to magnesium deficiency or overactivity of calcium sensing receptor, or it could be secondary to the failure of the PTH action. And the example is pseudohypoparathyroidism due to G protein abnormality. Other causes include failure of the release of the calcium from bone. Um, the causes are osteomalacia, secondary to vitamin D deficiency, vitamin D resistance, and renal failure. Other causes include inhibition of the bone absorption. The Uh, This could be related to hypocalcemic drugs like cisplatin, calcitonin, or oral phosphate. Or other cause could be related to increased uptake of calcium into the bone, like the osteoblastic metastasis, like the prostatic cancer, or hungry bone syndrome. Um, Furthermore, this can be secondary to complexing of calcium from the circulation, like increased albumin binding in alkalosis. Acute pancreatitis. In acute pancreatitis, there is formation of the calcium soap from the autodigestion of the fat. Abnormal PTH and vitamin D metabolism is another mechanism, and furthermore, this is related to the phosphate infusion. Multiple blood transfusion can also cause hypocalcemia. This is because of the complexing by the citrate. Pseudohypoparathyroidism. It is due to resistance to parathyroid hormone action due to defective signaling of PTH action through the cell membrane receptor. It also affects the TSH, LH, FSH, and growth hormone signaling. Most commonly caused by the autosomal dominant mutation of the GNAS1 gene, and there is significant imprinting with maternal transmission leads to full-blown syndrome of hormone resistance, and the paternal transmission causes only phenotypic features of Albright heredity osteodystrophy. So Albright heredity osteodystrophy, patients with the most common type of pseudohypoparathyroidism, that is type 1A, have a characteristic set of skeletal abnormalities known as Albright hereditary osteodystrophy. This comprises short stature, obesity, round face, short metacarpals. Some individuals with Albright hereditary osteodystrophy do not appear to have a disorder of calcium metabolism. In the past, the term pseudo-hypoparathyroidism has been used to describe these features. However, it is now clear that these reflect different manifestations of the same underlying genetic defect as a result of imprinting. In the light of the same underlying etiology, there has been a tendency to avoid the more cumbersome designations and to refer to all such patients as having Albright hereditary osteodystrophy. The investigations of hypocalcemia include serum calcium, PTH. The presence of a low or even normal PTH concentration implies failure of the PTH secretion in the presence of hypocalcemia. Total vitamin D, magnesium, Ellsworth forward test can be performed if pseudo hypoparathyroidism is suspected. That is the measurement of the serum and urinary phosphorus after IV administration of parathyroid hormone. The treatment of hypocalcemia would depend on the severity. If in case of acute symptomatic hypocalcemia is a medical emergency and demands urgent treatment, whatever the cause. Treatment of chronic hypocalcemia is more dependent on the cause. So the treatment of acute hypocalcemia, patients with tetany or seizures requires urgent IV treatment with calcium gluconate, which is less irritant than the calcium chloride. And the solution should always be further diluted to minimize the risk of phlebitis or tissue damage in case extravasation occurs. Initially, 20 ml of 10% calcium gluconate should be diluted in 100 to 200 ml of 0.9 saline or 5% glucose and infused over about 10 minutes. Repeat if symptoms are not resolved. Care must be taken if the patient has heart disease, especially if taking digoxin, as too rapid elevation of the calcium can cause arrhythmias. Cardiac monitoring is advisable. In order to maintain the calcium, a calcium infusion is required. 40 ml of 10% calcium gluconate should be added to 1 liter of saline or glucose solution and infused over 24 hours. The plasma calcium should be checked regularly, not less than 6 hourly, and the infusion rate adjusted in response to the change in concentration. Failure of the plasma calcium to respond to infused calcium should raise the possibility of the underlying hypomagnesemia. This can be rapidly ascertained by plasma magnesium estimation, and if appropriate, the magnesium infusion should is commenced. In circumstances where hypoparathyroidism could be predicted, such as block dissection of the neck, infusion of calcium gluconate in an initial dose of 50 ml 10% solution diluted in normal saline over 24 hours should be given to avoid post-operative hypocalcemia. This dose should be adjusted in the light of the regular calcium estimations. Once oral or NG tube intake is possible, calcium and active vitamin D metabolites should be substituted as above. And chronic hypocalcemia. In case of hypoparathyroidism, the target serum calcium should be at the lower end of the reference range. The reason for this is that the renal retention of the calcium brought about by the PTH has been lost. Thus, any attempt to raise the plasma calcium well into the normal range is likely to result in unacceptable hypercalciuria with the risk of nephrocalcinosis and renal stones. In patients with mild parathyroid dysfunction, it may be possible to achieve acceptable calcium concentrations by using calcium supplements alone. If used in this way, these need to be given in larger doses, perhaps as much as 1 gram elemental calcium 3 times daily. Majority of patients will not achieve adequate control with such treatment. In those cases, it is necessary to use vitamin D or its metabolites in pharmacological doses to maintain plasma calcium. The more potent analogs of vitamin D, such as calcitriol or alpha-calcidol, have the advantages over the high-dose calciferol that it is easier to make the changes in therapy in response to plasma calcium levels. If hypercalcemia occurs, it settles much more quickly following withdrawal of these compounds than calciferol. The dose of vitamin D metabolites is determined by the clinical response, but usually lies in the range of 0.5 into 2 micrograms daily of one of the potent activated vitamin D analogs. Serum calcium must be checked on ongoing basis, and the close monitoring should occur around times of dose adjustments. It is essential to ensure an adequate intake of calcium as well as appropriate doses of activated vitamin D analogs. In some patients, it is necessary to give calcium supplementation, particularly in the young. PTH is not yet approved therapy but may improve the quality of life. Pseudohypoparathyroidism. The principles underlying the treatment of pseudohypoparathyroidism are the same as those underlying hypoparathyroidism. Patients with the most common form of pseudo-hypoparathyroidism may have resistance to the action of other hormones which rely on the G protein signaling. They therefore need to be assessed for the thyroid and gonadal dysfunction because of the defective TSH-R gonadotropin action. If these deficiencies are present, they need to be treated in the conventional manner. Overactivity of calcium sensing receptors. This leads to a condition known as autosomal dominant hypocalcemia. It's a benign condition in which the hypocalcemia is usually asymptomatic. Treatment should be avoided in the absence of these symptoms, as elevation of calcium levels, even to within the normal range, may cause renal impairment. Thank you.